Good morning. Hello. Welcome back. Good morning. Great. So I really wanted to thank those of you that were able to join us last night at the farm. There we go. Yeah, did you have a good time? We had a great time out there. I think there was a few of us that stayed at the end. There was a little dancing. So for those of you that missed that, I know, it was awesome. It might have been me dancing, but maybe not. Anyway, we had a really great time out there last night, and really enjoyed. Some of you have been coming up and letting us know that you're having a good time, which is awesome, and learning lots of new things. And so today we have with us some of our federal partners, and we're really excited and really fortunate that they could come and speak with us about some things happening at the federal level and also around recovery approaches that I think you're really going to enjoy. But before we get to that, I just have a few housekeeping items. One is for those of you that are getting CEUs. Unfortunately, some of you have forgotten to pick up your packets. You need the packets, else you won't be able to get the CEUs. So be sure to go to the registration desk and get your packet. And then for those of you, I won't call out who said this, but they said, I don't have a license except for my driver's license. I fall in that category too. You do not need to be scanned. So if you're wondering and you're standing in line to get scanned, you don't need to be scanned. We're not tracking you. We're just tracking those folks with the CEUs. So at the end of the session, there'll be folks standing out back just to be scanned if you're getting the CEUs. So thank you for that. And then also, just one last thing is we're going to have two speakers this morning. After they are done, we're going to move into a question and answer session. And so what you'll see in the middle of all of your tables are some index cards. So first we're going to have Matthew. He's going to come speak with us. So if you have a question for Matt, all we ask if you could just put Matt's name at the top and put your question. And then after he's done, we'll collect those, and then we'll do the same for Tyler as well. And then once we're completely done, we'll move into the question and answer. So if you have a burning question, please write that down, and then I'll come up and we'll collect those for you at the end. So with that, with no further ado, I'm really pleased to introduce this morning Matthew Clune. Look, Matthew, we've been talking so much, I had not even looked at your last name. But Matt and I have been thick as thieves over the last few days, talking a lot about this area. And he is one of the leading experts at SAMHSA. When we were looking for a speaker around recovery, he came very highly recommended to us. So we're really excited to have him speak today. He did not want me to read all of his bio, which I always appreciate as a host. So his full bio is in the program guide. But I do want to say that he has a really neat background, and not only in working with SAMHSA, but he has a lot of also background in touching the justice-involved population and in other areas around behavioral health. And with no further ado, I'd like to bring Matt to the stage.
Good morning. Thanks, Marlise, for that nice introduction. And I have to learn the technology here, so please bear with me. I've always wanted to say, good morning, California. That was kind of weak, just like I used to say in group. Good morning, California. Yeah, right, okay. I'm really happy to be with you today. My name is Matt Clune. I'm a person in long-term recovery. And what that means for me is that today I have an opportunity to give back to society. I've also been blessed with a wife and a daughter who's 15 now, who have never seen me in my darkest hours. And I just can't even describe the doors that have opened and the way my life has changed. So I feel very blessed to be here. I'm also privileged to be a federal project officer, as GPOs, as you might know them. And I essentially handle the recovery portfolio for SAMHSA. And so I think that's why I got plucked for this particular assignment. And I've been learning a whole lot about your state and happy to plug in, especially about a topic that I'm passionate about. So I've got a lot of content that I want to push out to you folks, and I don't know if I'm going to get to all of it. So the way that the slide deck is organized is I want to talk a little bit about the need for treatment and recovery support services, which I think we all know. But I'd also like to talk about, where SAMHSA has been around recovery support and ROSC and where are we going, and the unique role of peer support. I know you've got a Section 1115 waiver that's kind of turned on the lights for peer-based support and other recovery support services, and how to kind of conceptualize that. That's one of my aims today. And I really want to do a call to action or a call to arms to see who out there, and I know you're there, are the leaders of your next wave of the recovery movement in California. So I think we all know that addiction takes a tremendous toll on society, that it not only impacts the individual who's got a substance use disorder, but it impacts their family and their loved ones. It impacts the employers and our GDP. They wind up in our justice system and institutions, and it impacts families and the community. But there is hope. Folks do recover. Millions of Americans are living in recovery today, living healthy and productive lives. The data's a little rough around this because of the stigma associated with coming out about your recovery, but some 24 million Americans are presently living in long-term recovery, and as a function of that, they've been able to give back to their families and their communities and their jobs, and live healthy and life-sustaining lives. I just happen to be one of those faces and voices out there, but there's some in this room I know for sure, and millions across America. So, like most of you, I spent the bulk of my career as a provider, really. Kind of worked my way up the food chain as clinician, manager, etc. And I'm sorry, this was the only picture I could find of like a group, although the furniture looks a lot nicer than the furniture I used to have. But I don't know. This must not be a public facility. But anyway, in reflecting back on that period of my life, there were always those clients who you felt that you were able to reach. In my mind's eye, I can still see some of them, and I'm sure that you either presently have them on your caseloads, or you have clients who you touched and you made a difference. But there was always this nagging concern for me that, it just wasn't enough, that somehow, we weren't quite fully doing our job. We weren't doing warm handoffs to the next level of care. We weren't providing the kinds of recovery support services that really increased the probability that the individuals who bit the treatment apple while they were in our programs had a chance at long-term recovery. And they would wind up back at the front door of the treatment center, or you'd hear about Johnny getting locked up, and you know the story, right? So what does our system of SUD treatment look like now, substance use disorder treatment look like now? I tried to come up with the most apocalyptic picture that I possibly could for this fragmented system of care. That could be a California freeway if you choose. But the idea is I just want to underscore what I was mentioning earlier, which is that we often don't do a really good job of making sure that our clients move from one level of care to the other, not only after discharge, but if they relapse, moving them back into a more intensive level of care. They also don't typically have the kinds of resources that they need. I was always frustrated by the fact that I couldn't put my clients, they had to go back to the public housing projects they used to live in, or in the, the really negative family environments they were in, that kind of led to their addiction and wasn't supportive of their recovery. So some 15 plus years ago, a guy named William White, who worked with Arthur Evans and Tom Kirk in Connecticut, developed this thing called recovery-oriented systems of care. And I want to go into what ROSC is the acronym, means, and what that might mean for the state of California, and kind of frame out kind of where you are right now. You're in a disruptive cycle, but you're kind of in the storming stage, I guess. You've got Medicaid waiver going on, but I also want to provide you with some hope, just like our clients, about where you might go in the future. Before I do that, I was asked to talk a little bit about what SAMHSA has done and why particularly we've gotten behind this notion of recovery-oriented systems of care and recovery support services. So real briefly, SAMHSA has 6 strategic initiatives. They're prevention, health systems integration, trauma and justice, recovery support, which we're going to talk about today, health information technology, workforce development. Some of you may know Captain John Perez, who's SAMHSA's regional administrator. All the RAs around the country have been really working on workforce development, and hopefully they've touched you out here in California. So the Recovery Support Strategic Initiative is one that is led by Paolo Del Vecchio, himself a man in long-term recovery. And let's talk a little bit about what that entails. So Marlise asked me to promise, rather, that I would point out the poster boards in the back, which highlight SAMHSA's 10 guiding principles of recovery. These are not monolithic or comprehensive, but simply meant as useful tools for you. And I'd like to just spend a second on each one, because I think you instinctively all know where we're going here. So recovery emerges from hope, right? For me and others, it meant that, despite going in and out of rehab, in and out of jails and prisons and institutions, that I needed someone to talk to who'd been there, done that, and could show me that recovery was possible. When I went back to the rooms with my head down and humiliated and say one day back, I needed someone to let me know that that was part of the process, it was okay, and hear their story about how they got well. Recovery's person-driven, so like we try to do in our treatment plans where we talk about partnership, we really mean it in ROSC. We really mean that the person who's seeking care is an equal part of their recovery process, and it's self-driven. Recovery occurs via many pathways. Well, what do we mean by that? There was a workshop yesterday on, I think it was entitled Big Book Thumpers versus Pill Pushers. And I'm not sure that I would exactly craft it that way, but essentially the idea is that there's no wrong door to recovery, right? There's multiple pathways. What worked for me may not work for you. And we need to respect and honor that. And when we talk about medication-assisted treatment, that's a topic that frequently comes up, as I'm sure you know. Recovery is holistic. Everyone, I think, here knows what that means. We treat the whole person, right? We don't just treat the illness, we treat the fact that this individual might also have, in addition to behavioral health problems, primary health problems, may have issues with their family, reintegration, housing, employment, how do I get my driver's license back, etc. Recovery supported by peers and allies. Just as I spoke to earlier, having someone with lived experience of recovery from substance use disorder was kind of a hallmark for me, and kind of extended out that vision that I too could grab onto that someday. And building that idea into our system seems to change the whole culture of the system. I'm going to return to that topic later. Recovery supported through relationship and social networks. This is similar to early 12-step programs and other, things like Smart Recovery and Celebrate Recovery that have come along. I understand from having lunch with some folks who work in more rural areas that telehealth is especially important. I would highly encourage you to connect with one another across this ginormous, fantastic state that you have. I'm just getting my arms around it, really, and use social media to, for those who are true believers and have drunk the Kool-Aid like I have, you're a more palpable force if in greater numbers, right? Recovery is culturally based and influenced, another workshop that we had. I don't really like the term culturally competent, but culturally sensitive maybe. So we need to be mindful of the fact that our clients or participants are coming from very different backgrounds and cultures, and that what we offer them in the way of treatment and recovery support needs to be tailored to their needs and their culture. Oh boy, can't underestimate this. Recovery is supported by addressing trauma. So many of those with substance use disorders have gone through horrible, traumatic, I feel like I'm preaching to the choir here, backgrounds. And so if we're not mindful of this, and if we don't tailor our treatment planning and our evidence-based practices, et cetera, to the fact that these folks have been through enormous trauma, then we're likely to fail. Recovery involves individual, family, community strengths, and responsibility. I don't want to spend too much time on that because I think it's self-explanatory. And recovery is based on respect. So we have witnessed the criminalization of addiction. Other chronic illnesses like diabetes and asthma, we don't lock people up for. I really don't understand why we lock up folks for addiction. And I think we need to be mindful of that. So next I'd like to take a look at, we've taken stock in the fact that we have a fragmented system of care right now in SUD that's changing a bit in California right now, right? Tremendous opportunity for you guys. So let's take a look at what the universe of recovery support services might look like. And I'm not going to read through this list, but many of you are already doing most of these things. You did them before the Section 1115 waiver came through. But perhaps newer on the list are peer supports. Sober housing's been around for a while, and Oxford housing's been around, but we need more. We need better quality. Recovery community centers. If you're not sure what that is, we can talk more later. And recovery community organizations, who are often the nonprofits who host this constellation of recovery support services, housing, and peer-based services, et cetera, all underneath one umbrella. So we've talked about the University of Recovery Support Services. I picked out this illustration because I think I just wanted to communicate one simple idea. That is, if we're to develop this ROSC ecosystem, what should it look like? So it should include all those recovery support services we talked about, right? But the principal takeaway from this slide is that you'll notice that clinical care, the treatment and rehab circle there, or ellipse, is but one of the many recovery support services that we need to offer our clients. That's what ROSC has taught us. That's what's happening in other states around the country. And if you take away nothing else from this little pitch here today, I hope you take that away. So work with your natural colleagues and partners in this. I also want to point out that as a nation, we haven't quite gotten to this ROSC ecosystem in most states around the country. We've gotten to systems that added lots of recovery support services like you're doing right now. But they don't all quite fit together seamlessly. And William White, I hope I don't overuse his name, but he really is the grandfather of this movement. WilliamWhitePapers.com, everything you ever wanted to know about. There's a shout out, thank you. You know, he warned us that if we don't look at the system as a whole comprehensively, we'll end up with an additive, you know, add-ons, these recovery support add-ons. And in my experience, that's really what's been happening. I can't really point to many jurisdictions or states that have fully embraced this recovery-oriented system of care. I'll talk about that in a moment. And perhaps the reason that hasn't happened is because without a conceptual framework or philosophy or a paradigm shift to make this a transformative change and not just an additive change, we've got a bunch of recovery support services that, you know, cafeteria style, the client, clinician, program director can kind of grab onto, right? What's the glue that holds it all together? So Bill White and others developed a recovery management paradigm, and I just want to touch briefly on all of these. How are we doing on time? Yeah, okay. I don't know. So lowering the threshold of entry to recovery. What does that mean? It simply means that, you know, if only 1 in 10 people are getting treatment for the issues, for their addiction issues, then we need to do better at that. And maybe we need to lower the bar or create more spaces for them to gain traction in their recovery, like recovery community centers. Redefining the role of the person in recovery. Well, what does that mean? That gets back to that equal partner thing and self-directed care. And the flip side of that is the person on the other end of that partnership, the counselor or clinician. Less hierarchical, more partner-based in this relationship, and mutually working together to help the individual usher forward in their recovery. Viewing treatment as a multi-tiered intervention. I think most folks know what I mean when I say that, but we need to get away from episodic treatment and be mindful of the fact that you know, addiction's a lifelong illness, which requires multiple levels of care. And the more that they talk to one another and the more that they are collaborative in nature, the greater success of the folks that they are trying to treat. Shifting the service emphasis from stabilization to long-term support. I just hinted at that. Re-engineering assessment to be global. I did ASIs forever, and I looked at, just like you guys, folks, you know, the guy in front of me's addiction history and their mental health history and their criminal justice history, but I'm not quite sure that I fully looked at globally all that was going on with them with family and health and home and that kind of thing. So more globalization of assessment. Again, emphasizing sustained monitoring, self-management. When folks leave our program, what do we do with them? How do we ensure that we've got our eye on the long-term picture? Assessing recovery is a multidimensional process. I think that's self-explanatory. There should be a number 9 there, but evaluating service events based on their short-term, not on their short-term effects. Again, the long-term picture, it's a chronic illness. What are we doing when they leave our program? Evaluating recovery programs in terms of the dynamic interaction among persons and families. It sounds cliche, but addiction is a family illness. We are remiss unless we take into account all the important players, and they're not always bio-family members, right, in that individual in front of us in their lives. So by show of hands, may I ask, I know this is, some of you all have been working with peers and recovery coaches. I just use the word peers because there's too many darn names for them. But how many of you are working with peers in your programs or are county administrators and are supporting peers? I see a few hands go up. Okay. Okay, more work to be done. Peers to me are really the glue. Individuals with lived experience not only bring unique value to the table on that treatment and recovery team in a non-clinical way, but they seem to have a transformative power on the whole culture around them. Suddenly people who have been in the closet about the recovery are more open to talking about it, and it seems to have kind of an effect on the entire culture of recovery, which is an area that, if I might suggest, and I'll end up with this, that California begins to move in. Not easy to change a culture, one step at a time. So, not too far away from you, and hard to believe, but in the state of Texas, they have launched a very ambitious experiment in developing recovery-oriented systems of care around their state, this ginormous state of Texas, rather. And they contracted with 22 recovery support service providers. They also contracted with UT Austin to do the evaluation. It's a few years in the running, and they are showing remarkable results. Just within the last 2 years, for the individuals that have been showing up at recovery community centers and receiving recovery support, some 54% of long-term coaching participants owned or rented their own living quarters at 12 months out, as compared to 32% prior to that. Overall employment increased by 23%. Average monthly wages, and this one really blows me away, increased from $249 a month to $865. These are all averages. And remission rates for individuals remaining abstinent also spiked. So more work to be done out there, but I mentioned the Texas experiment because it's not too far away if you want to do a field trip. So before I wrap up, I want to focus real briefly on what SAMHSA is doing today around recovery support, particularly how we finance things. This CSAT's recovery portfolio is one that I oversee for the most part. Probably our oldest grant program is Recovery Community Services Program, statewide network, or RCSP as many of you know it. That's been around since 2002. That's really our grant program that is kind of infrastructure development, capacity development, advocacy, working at the State House, messaging, all things that I think would be value added to the state of California. Access to recovery almost around the same period of time, in somewhat of a different way, voucher-based, not Medicaid support, provided vouchers for all the kinds of recovery supports that we've been talking about today. The TCE peer-to-peer program is a newer program that I oversee. That's been around since 2014. And the way to distinguish that between RCSP is really that's our services-oriented program. So I've got 17 grantees around the country who are doing lots of peer-to-peer recovery support, creating amazing change, creating culture change within their states and communities. Very interesting work. One of those grantees, and I wish there were more, is in LA. They're called the Ahmad Institute. They're in South Central. They're working with men with HIV who also are comorbid with substance use disorder. CARA, I don't know if that's a familiar name, but the Comprehensive Addiction and Recovery Act, recently passed by Congress, developed a new grant program called Building Communities of Recovery that has this ugly acronym called B-Corps. I didn't have a say in that. But B-Corps, the way to think about B-Corps is it's really an amalgamation or a hybrid of RCSP and peer-to-peer. So grantees could do and/or. They could either do the advocacy piece and the infrastructure development or the services side of things. Those awards are about to come out any day now as we speak. So in addition to the grants that SAMHSA supports. We also have a number of contracts that I really wanted to highlight because I would avail myself of them. They provide all kinds of interesting, awesome resources that I think would really help you move to the next phase here. So there's, many of you are familiar with SAMHSA's Brass Tacks TA Center. I used to work for them, actually. They do fine work. And they, like many other SAMHSA contracts, provide a range of policy academies, technical expert panels, national symposia. They also provide free TA to states, counties, local treatment providers, local recovery community organizations. So call them, write them, use my name. If you want to, if you're not sure where, I spoke to a woman yesterday who'd worked in residential treatment and is now in charge of recovery support services program, and she didn't really regard herself as a recovery community organization. And so I let her know about Brass Tacks. And I said, you're really an RCO, and you ought to give these guys a call because they can help you move from where you are today to where you want to go. There's a new contract out. I'm getting the signal, so I'm going to wrap up soon. Thank you, Crystal. So we have a new contract out that has, that will be awarded any day now, that has a really long, and we just refer to it as the S&C SUD, too many acronyms, huh? Recovery Support TA contract. It's very much like Brass Tacks, so the policy academies and the free TA, and it supports the grantee portfolios that I just described. But the real takeaway on this one that I want to underscore for you, and I'm looking at the state table over here with the state officials, is that, not to put you on the spot, but so these state policy academies, both in Brass Tacks and that are embedded in this contract, allow state consortia of SSA officials, county officials, provider organizations, RCOs, and other advocacy organizations to apply as a coalition. And the distinction between, and this was rewritten purposely this way, and rewritten purposely in this way because ROSC hadn't really taken off the way we would like it to, is that if you are awarded a Policy Academy grant, you'll get TA site visits. You'll all come together with the other states at SAMHSA and DC, be provided with a host of materials and help develop an action plan for your state. How do you get from here to where you want to go 5 years from now? In addition to that, and in contrast to Brass Tacks though, you also get national expert consultants who are going to follow you longitudinally and work with you and come out to the state and visit everyone who's engaged in this process. And so I think this is a real game changer, and I had a hand in, I have a personal bias, I had a hand in rewriting this contract, but we're hoping to move the needle forward on ROSC through this contract. So what are our next steps, guys? We need more infrastructure development. We got a Section 1115 waiver, process of disruption. Often out of process of disruption comes innovation and creativity, so remain hopeful, just like we ask our folks in recovery to do. Once we do that, how do we sustain it? Access to Recovery, another large SAMHSA grant, provided lots of recovery support services, but sometimes in the wake of the federal dollars drying up, unfortunately, that recovery-oriented culture didn't manage to gain traction. Sometimes it did, sometimes it didn't. So think about how are we going to sustain these recovery supports, in addition to the Medicaid support. And very importantly, and I'm just going to speak from the gut here. I had lunch with a bunch of folks yesterday. I talked to lots of people. I went to a number of different workshops, and I really get the sense that if you're going to bite onto this recovery-oriented system of care apple, and you're going to drink the Kool-Aid as I have. You've got to change your culture here in the state of California. You really need to embrace this. And you might say, well, God, Matt, of course we understand recovery. That's what we do, right? But, and I get that, because as a treatment provider, that was our key goal. But the idea is providing care for the long term, over the life cycle, chronic illness, and collaboration. How do we do that, and how do we build a system around that that's transformative? And this is not mutually exclusive, but while you're doing all of that, please do recovery outcomes research. We have a dearth of research in this field. We want to be able to demonstrate that what we're doing works, and without data, there will be no money. So I'm not saying that to you, I'm saying that as a reminder to myself. So I want to leave you off with this beautiful slide and a little video. So aim high, dream big. Don't circumscribe what's possible. Think outside the box. Get away from the office some days and imagine, a blank sheet of canvas and what it should look like in the state of California. And I really want to kind of put a call to action down for those in the audience and ask you, who are the recovery leaders in this audience? Who are the leaders that are going to step up and develop their own recovery community organization? In many states around the country, there's one recovery community organization that has many chapters throughout the state, or there's several recovery community organizations. Who are those leaders? I suspect many of them are right in this room. So I'd like to leave you off with a video that, on dark days and when I'm up to my eyeballs like you guys, with too many tasks and deliverables, always kind of reminds me of why I got into this whole mess. And so if I might, could we cue up this video, please?
Recovery has given me peace. I can live every day, get up and be excited about it.
Recovery is possible.
There is hope.
It's going to get better.
I got me back.
Life can really be good.
There is a life waiting for you that is so much bigger and more beautiful than you could ever hope to dream for yourself.
More people die from overdoses than car crashes.
These deaths are preventable.
Today is the beginning of a national awareness.
California's own.
We are a family.
We were nearly forced to cancel this show because of Hurricane Joaquin, but then one of our board members said, "My whole life was a hurricane for 25 years because of addiction. Are we really gonna let a little rain get in the way?"
The real stars in this show are actually not the people playing, it's you. Each and every one of you who have come here to break the silence.
As long as I am Surgeon General, we will face addiction together.
There is hope after addiction through the power of recovery.
Today is the day when the silence ends. Our presence here on this National Mall is not just about ending our collective silence, but it signals the beginning of a new era of accountability for our trusted servants, the people we elect up on that hill a few blocks away. No longer will we allow our congressmen to be able to ignore the voice of the 85 million Americans impacted by addiction.
It's been an honor. Thanks very much.
I want to hear a woo after that video. Dang. There we go. Woo. All right. So anybody has questions for Matt? Please feel free to raise your hands in the air like you don't care. And some folks will come around and collect your cards. And you'll also have another opportunity after our next speaker. So it is a huge pleasure to introduce our next speaker. And I was thinking about Tyler. So Tyler Sadwith is the lead with CMS's Innovation Accelerator Program around substance use disorders. And he also helps many states in working towards their 1115 waiver for SUD services. He's very popular around the nation. I was just back in Baltimore a few weeks ago, and everyone's like, Tyler! And we're like, wait, Tyler's ours. He started with us in California, but no, he is really spreading wisdom really across the nation in the area of SUD services. But on a personal note, I would say I was thinking about Tyler is probably one of the few people in my career that knows how to push me forward, where I already feel like I'm moving forward and I'm like kind of going like this, you're doing good, you know, you got a lot of good stuff going, and then I get a call from Tyler and there's like 500 questions and what are you doing around this, what are you doing around that, what about this, but always to help grow us at the state level and to push us forward. So it is with an utmost pleasure to introduce you Tyler Sadwith.
All right, well, thank you, Marlies, for that wonderful introduction, and thank you, Matthew, for your remarks. My name is Tyler Sadwith, and I have substance use disorder innovation syndrome. Unfortunately, I don't have a great video, and that is a great video. It's online. You should check it out. And I don't have slides that will be helpful, and I apologize in advance for that. But I'd like to share about, my work with states in this space. So as Marlies said, I work for the Federal Centers for Medicare and Medicaid Services, or CMS for short, and my position is Substance Use Disorder Lead for the Medicaid Innovation Accelerator Program. And over the past few years, I've had the privilege and the good fortune of working in partnership with a number of states, including state Medicaid agencies and single state agencies for substance abuse, to help develop policies and implement strategies to improve the care and the outcomes for individuals with SUD. And I've had the honor of working closely with California, especially with the team at the Department of Healthcare Services, with Marlies Perez and Karen Baylor and others, as they work to design and develop the Drug Medi-Cal organized delivery system in collaboration with a number of folks in this room. And let me say that if you've never had the pleasure of interacting with the federal government and negotiating an innovative waiver on a brand new policy to help kick the door down for other states, you should know that if were it not for the resilience and the dedication and the vision of Karen and Marlies, millions of Medicaid members would not have access to the treatment services that they need and that they have today. So, and so I know this room is familiar with the DMC ODS, so what I'd like to do this morning is just broaden the scope a little bit and share about the federal perspective on prevention, treatment, and recovery services. I'd like to highlight some of the actions and the approaches that not only CMS is supporting states to work on, but some of the efforts that states are undertaking to support practices that are occurring on the ground. And I'd like to highlight specifically some of the approaches that pertain to opioid use disorder specifically, given the epidemic that's reverberating across this country. So I'll spend a little bit of time describing how CMS is approaching SUD and opioids, and wherever possible, I'm going to shout out and share some of the state and local examples. But before I talk about what CMS is working on, I want to take a moment to celebrate just a few of the many successes that counties in this room have been able to achieve on their own accord and under the waiver, because I think it's important to count our wins. So first, I'd like to give a shout out to San Mateo for being the first county to develop an implementation plan, actually tied with San Francisco for that, being the first county to submit a managed care contract, and being the first county to begin service delivery under the waiver, which began nearly 1 year ago. And close on San Mateo's heels is Riverside. Riverside went live in February, and I actually had the opportunity to visit Riverside and meet with beneficiaries, with providers, and with the dedicated county team that's operating that program. And I'd just like to quickly share a few highlights from that trip. So prior to going live, Riverside had been operating a call-in center for behavioral health services, which historically received about 140 calls every month. Within the first 6 weeks of launching their waiver, Riverside fielded 6,488 calls from people seeking information about addiction treatment services. And that was shown on a chart that Karen showed yesterday. So Ryan and his team passed out so many business cards in the community that they were just inundated, which shows how vital these services are. It shows the unmet need, and it shows how critical it is to offer coverage and to expand access. In Riverside, we heard directly from residents who shared about how the new waiver services are helping them to achieve sobriety and to reunite with their families. People shared how they were prescribed buprenorphine, which previously wasn't available, and how they were admitted to residential treatment the same day that they called, which is just a testament to the county's job on managing referrals. And one litmus test was meeting with providers. Despite the challenges of turning on new billing codes, the overall feedback was positive from providers. They shared how they're increasing the amount of therapy provided in residential programs, how they're individualizing treatment based on ASAM assessments, and how their patients are able to receive OBGYN screenings and primary care thanks to the IMS while they're in treatment. And I think my favorite quote from that day was a provider who said, "The waiver is working." And if you felt the earth move a little bit last month, that's because Los Angeles went live on July 1st. So Los Angeles is opening up new services, a new call line, a new access line, introducing comprehensive ASAM assessments, and enhancing their service and bed availability tool. Los Angeles serves more Medicaid beneficiaries than many states in the country, and we recognize how significant that project is. And finally, I'll just say kudos and congratulations to San Francisco, Santa Clara, Marin, and Contra Costa, who have all begun service delivery under the ODS, and to Sonoma and Santa Cruz, who are waiting in the wings until October. So like I said, these are just a few of the many successes. Let's give a round of applause to the county partners and to the providers. So I'd like to spend a few minutes describing some of the work that CMS has devoted to the opioid crisis and to supporting states in their efforts to reduce substance use disorder. So along with other federal, state, private, and community partners, CMS is committed to addressing the nation's opioid epidemic. And the agency is focused on 4 priority areas: implementing person-centered and population-based strategies to reduce the risk of opioid use disorders, overdoses, inappropriate prescribing, and drug diversion, expanding naloxone use, distribution, and access, and expanding screening, diagnosis, and treatment for opioid use disorder with an emphasis on increasing access to medication-assisted treatment, and disseminating evidence-based practices for acute and chronic pain, specifically non-pharmacological and non-opioid therapies as first options for pain management. And we aim to meet these goals through a variety of activities in our marketplace and in our Medicare and in the Medicaid programs. So starting with prevention, I'd like to highlight some of the work CMS is doing with prevention and some of our efforts to reduce future incidents of substance use disorder. We know many prevention programs operate, outside of the direct Medicaid funding stream. So when we work with states, we learn about how their prevention efforts and their prevention dollars, including through the SAMHSA block grant and the SAMHSA state targeted response grant set-asides, are continuing those important services and are even enhancing them with the new focus on opioids. And one primary goal of CMS is to reduce inappropriate opioid prescribing, and we're working to do so in a number of ways, primarily through providing information and education to providers and to patients. We distributed a drug diversion toolkit for prescribers and for pharmacists participating in Medicare and Medicaid. We collaborated with the Centers for Disease Control and Prevention to launch their guidelines for prescribing opioids for chronic pain. We shared the CDC guidelines with Medicare and Medicaid providers, and we're partnering with the CDC on an opioid safety poster campaign to promote safe prescribing in clinical practice settings. And we're honing in on steps that state Medicaid agencies can take as well. And this is actually a priority area, as Medicaid beneficiaries are prescribed opioid pain relievers at twice the rate of non-Medicaid patients, and they're at significantly higher risk for overdose and death associated with opioid pain relievers. And in particular, we're actually honing in to provide information and options to states so that they can manage the coverage and the prescribing of methadone when used as a pain reliever, given that methadone, when used as a pain medication, actually accounts for a disproportionate share of prescription opioid-related deaths. So we've held national learning opportunities and provided guidance to states about pharmacy benefit management strategies and options that they can take to manage the prescribing of opioids, such as reviewing preferred drug lists and removing preferred status, introducing clinical criteria, prior authorization, quantity limits, step therapy, and utilizing drug review, utilization review processes. We held a webinar to recommend that states review their preferred drug lists and consider removing methadone from preferred status specifically as a pain reliever, and to ensure appropriate utilization of other opioid pain medications. We issued an informational bulletin highlighting options under Medicaid to manage the prescribing of opioids and ways to increase access and the provision of naloxone to reverse overdoses. And the Medicaid Innovation Accelerator Program held a webinar highlighting innovative state Medicaid policies that are in place to address prescription opioid misuse. So we highlighted really strong examples from states in this space, including New York, Oregon, Washington, and West Virginia. And the IAP, or the Innovation Accelerator Program, hosted a webinar when the CDC launched their guidelines. And on that webinar, Oregon actually presented an initiative they have to promote non-pharmacological treatment for neck and for back pain. And we're beginning to see the results already of states that are implementing the CDC guidelines. For example, Virginia implemented guidelines with strategies such as increasing access to non-opioid pain relievers, requiring prior authorization, quantity limits, and educating providers. And as a result, Virginia saw a 53% decrease in the number of opioid pills dispensed and a 49% decrease in related spending. And this is happening at the local level as well. Yesterday, Sonoma County described in a workshop how they collaborated with hospitals, with health plans, with FQHCs, and with clinics to develop, implement, and monitor opioid prescribing. States are also leveraging prescription drug monitoring programs, or PDMPs, to monitor opioid prescribing. So after New York required their prescribers to check the PDMP before writing a prescription for opioids, the state saw an 82% decrease in the number of patients that use multiple prescribers and multiple pharmacies for controlled drugs. Washington is leveraging their PDMP to identify individuals who use Medicaid to pay for one prescription and cash to pay for another. So now, I have to say a few remarks about data and the use of data in this work. So a core component of any federal or state or local approach to substance use disorder requires data analytics to understand the size and the scope of the problem. And while many states have a good handle on the prevalence and the need of substance use disorder in general, what we're beginning to see are states hone in on opioid use disorder specifically as a first step to developing data-driven strategies to tackle the crisis. So we've heard from states that are performing data analytics to size the magnitude of the opioid problem in their Medicaid population. They're looking at demographic and geographic dimensions. They're looking at the medical and behavioral service and the pharmacy expenditures for this population. So for example, they're taking claims data and they're looking at the diagnostic codes to identify OUD as a primary or secondary diagnosis, and then within this population, they're stratifying it by age, by gender, by zip code, by delivery system, to really titrate their understanding. So Pennsylvania, for example, they're working to identify counties that have the highest rates of opioid use disorder, and then within those counties, they're working to identify individuals that have been diagnosed with OUD, but have not been diagnosed by OUD by their primary care provider. So then this allows the state to do targeted outreach to those physicians to get them X-waivered to prescribe buprenorphine so that they can start treating people for opioid dependence who are already in their practice. And the Chief Technology Officer at the United States Department of Health and Human Services is working to harness data to address the opioid epidemic as well. The CTO is planning a summit and a hackathon in November where they're inviting coders and academics and researchers to squeeze data sets and run analyses to put the use of data at the forefront in addressing the opioid epidemic. So moving to treatment, I'd like to highlight some innovative federal and state efforts related to treatment services. So prevention efforts are indispensable for turning the tide on the epidemic, but we know that we can't put the genie back in the bottle. So moving from upstream efforts to midstream efforts, there's exciting things happening at the state level and at the practice level in terms of innovative treatment approaches in Medicaid. And CMS is actively working to support states in this space. So over the past few years, CMS has issued a number of informational bulletins related to substance use disorder. We partnered with SAMHSA and with the CDC and the National Institute on Drug Abuse to provide guidance on the use of medication-assisted treatment. I mentioned a bulletin that we issued last year describing options to manage opioid prescribing. This year, we issued a bulletin describing options and flexibilities that states have to expand access to naloxone, such as through the use of standing orders and collaborative practice agreements, so pharmacists can dispense naloxone and ensure availability in the community. And through initiatives like the Medicaid Innovation Accelerator Program, CMS is providing tools and technical support directly to states to accelerate delivery system reform on a number of programmatic areas, including SUD. And there are several ways that the IAP is supporting states on SUD innovation. For example, the IAP provides expert resources, coaching opportunities, and individualized technical assistance to states to help introduce policy and payment and program reforms to better serve individuals with substance use disorder. Through the High Intensity Learning Collaborative, we work closely with 6 states to introduce changes to their Medicaid program related to SUD, and the 6 states that were in the High Intensity Learning Collaborative are Michigan, Kentucky, Pennsylvania, Washington, Texas, and Louisiana. California actually raised their hand to participate, but we said, no, Marlise, you have to work on the waiver. And then in addition to the Learning Collaborative, the IAP provides and develops strategic resources for states that are seeking information on SUD innovation. For example, we developed an overview of the National Treatment Guidelines published by ASAM, including the provider and the service standards for each level of care. And with that overview, we also provided templates that states can use to compare their service coverage to see if it aligns with the continuum, and a template that they can use to look at their provider standards to see if they align with these national benchmarks. And the IAP is partnering with states to understand the use and the availability of medication-assisted treatment in Medicaid. So we know that not all practitioners that have the waiver to prescribe buprenorphine are actively prescribing it. We know those prescribers that do prescribe it are not always participating in Medicaid, and we know that beneficiaries who receive buprenorphine and other medication-assisted treatment are not always receiving the behavioral health services, clinical services, and wraparound services that they need. So we partner with states to conduct this initial type of analysis. We actually provided support for California to do this work, and I think that helped support their proposal to SAMHSA for the hub and spoke system grant, which Marlise described yesterday. And the Innovation Accelerator Program also works on a national level to connect states with SUD content experts and with leading practices and with leading states across the country. We've reached all 50 states, plus the District of Columbia, and many territories, perhaps not all, through our National Learning Series, which has addressed topics like designing opioid health homes, assessing provider and service capacity for network planning, designing service and payment approaches for MAT, and leveraging managed care contracts and contract language for performance improvement in SUD. And we're also developing quality measures for SUD. We're looking at continuity of care after detoxification as one option, and we're exploring measures related to duration and retention rates in medication-assisted treatment. And one last highlight from the Accelerator program. We've developed resources related to designing episodes of care and bundled payments for medication-assisted treatment specifically. And this work actually began as a request from a state to help develop a bundled payment for buprenorphine. So to meet that request, we began by identifying strong practice models that are in use today in state Medicaid programs. So we looked at the Vermont hub and spoke model. We looked at an office-based opioid treatment model in Massachusetts that uses nurse care managers to support the prescriber. And we looked at a model that includes inducting patients in specialty treatment settings and transferring them to primary care that is used in Maryland. And so for each model, we developed a clinical pathway that articulates the stages of treatment from assessment to induction to stabilization to maintenance to discontinuation. And we developed a corresponding rate design tool that reflects the practitioners involved and their salaries so that states can use it to design and develop rate approaches that reflect the underlying clinical infrastructure. These tools are on our website, and we may add more models to that list, such as Rhode Island, Virginia, and Missouri. So in terms of getting approval and federal funding from CMS, there's a few ways states are leveraging federal Medicaid authorities to administer their SUD program. States are using the Medicaid Health Home Authority as an opportunity to target the opioid issue. Health homes are a state plan option that can help states better serve individuals with chronic conditions. States can receive an enhanced federal match for family support, referrals, care management, care coordination, the use of health IT. So, Rhode Island, Vermont, and Maryland implemented Medicaid health homes specifically for opioid use disorder. And I think Marlise has shared that DHCS is working to incorporate or steal the Vermont framework. In addition to the Health Home Authority, there's an increased focus on leveraging Section 1115 Demonstration Authority, which are commonly known as 1115 waivers, for efforts on SUD. So as you know, California was the first state approved under the 1115 SUD policy, which allows for states to cover the full continuum of care for treatment, including residential treatment services that otherwise are not coverable under Medicaid because of the IMD exclusion. And there's a few other states with approved SUD waivers, including Maryland, Massachusetts, and Virginia. And as part of a department-wide effort, CMS is working in concert with other components on opioids. And one task we've been given is to modify that policy to provide additional flexibilities for states. So we're working to approve a number of additional states under that new policy, including West Virginia, Indiana, Utah, Wisconsin, Michigan, New Jersey, and others. So there's a few ways we're opening up that policy to help states. We're paring down the requirements. Previously, there was a fairly high bar set in terms of programmatic expectations that were required before we could approve the waiver. And so now we're transitioning to an approach where we essentially meet states where they are and provide an on-ramp so that they can build on efforts and meet those expectations over the course of the waiver. And we're also paring down the requirements for approval, so we're trying to set up a glide path to get from submission to approval more quickly. So states are, being asked to develop an implementation plan to describe the timeframes and the steps they'll take to meet the milestones, and they can submit those implementation plans, laying out that plan of attack after approval. And from a broader agency perspective, CMS is rolling out additional authorities and efforts to address the opioid epidemic. Our Center for Medicare and Medicaid Services is hosting a behavioral health summit on September 8th, and the purpose is to discuss ideas for a potential behavioral health care delivery and payment model for Medicare and Medicaid. And community health organizations, providers, and patient advocacy groups, caregivers, and others are invited to attend that summit and share their recommendations. And the Innovation Center is also considering new models, payment models related to opioid use disorder. So switching gears into recovery, I've been given the time signal. I want to talk about some of the dynamic ways that states and providers are using peer support specialists and recovery coaches to engage members and to sustain recovery. So states like Rhode Island have really innovative programs in emergency departments that use peers, coaches, nurses, and physicians to engage people when they present with an opioid overdose. So these programs are initiating medication-assisted treatment, providing naloxone, and facilitating referrals directly into treatment all before people leave the hospital. So peer workers and recovery workers can actually play a really crucial role in these moments when people are at their most vulnerable. So hospitals like Boston Medical Center, Yale New Haven, and others are combining immediate induction on medication-assisted treatment with the use of peer workers that are embedded directly in the emergency department setting to help facilitate referrals, and these programs are showing higher rates of initiation into treatment and treatment retention. And West Virginia is leveraging overdose encounters into treatment referrals by developing strategic partnerships with their ambulance providers, their treatment providers, and their hospitals to build a fluid process so individuals who have overdosed can get into medical care and get into treatment. So at the federal level, 3 weeks ago, as Marlise mentioned, CMS partnered with SAMHSA and with the CDC to convene state Medicaid and behavioral health leadership to support state efforts to address the opioid epidemic. We brought together 300 state leaders for a 3-day state opioid workshop in Baltimore, and I'd like to quickly share a few takeaways from that workshop as I conclude my remarks. So the core principle is the need for collaboration and coordination. We need to collaborate and catalyze efforts across agencies and across organizations, within states and across states to stop this epidemic, because it can't be stopped by one agency or by one part of our healthcare system. And we heard from a number of states about their ongoing efforts and their future efforts and their planned initiatives. So Washington is launching regional opioid projects for Medicaid beneficiaries that will begin in January 2018. And the regional approach reflects the different needs and the different solutions in urban areas and in rural areas. And Washington's developing a suite of opioid performance metrics to track and to test the effectiveness of these different regional approaches. Virginia is making headway on engaging their judicial system on the need for appropriate assessments and treatment recommendations for court-ordered treatment, to the point where their Secretary of Health is providing consultation and information to the Chief Justice of their Supreme Court to be shared with all judges. And their addiction medicine team is attending judges' conferences to provide and present information. Virginia also shared their work on implementing their 1115 SUD waiver at the workshop. And one neat thing that Virginia is doing as part of their waiver is establishing a gold card credentialing program for integrated MAT providers for office-based opioid treatment providers. So this gold card allows those providers to receive higher rates for counseling, to bill for peer and recovery services, and to bypass prior authorization. And as part of this work, Virginia engaged their managed care plans to pay a monthly fee to gold card providers to provide substance use care coordination for members with moderate to severe OUD. And this alludes to the business case that Steve Kaplan mentioned yesterday about engaging your health plans. And Virginia is also developing quality metrics for these gold card providers to report. I think a major takeaway that we heard loud and clear from other states is that they're interested in heading down a path to ensure that people are able to receive comprehensive medication-assisted treatment. Pennsylvania, Rhode Island, and California's own Marlise Perez shared their work on designing and implementing MAT models that treat the whole person using a team-based approach. And one state Medicaid director said that they found religion at the workshop on the need for improving access to high-quality MAT. And we heard the Arizona Medicaid director say that the opioid epidemic is one of the most, if not the most, difficult issue he's ever faced in 8 years as his tenure as director and over 20 years in state government. On June 5th, their governor issued an emergency declaration which requires real-time reporting of robust, timely, and accurate data. Arizona presented their opioid dashboard at the workshop. It includes real-time data that's available for the first time on suspected opioid deaths, overdoses, neonatal abstinence syndromes, and naloxone doses dispensed and administered. And other states were clamoring on the need to have robust data collection and data information sharing systems. For me, the most important voice at that workshop was from a father whose son died of this disease. His story was powerful, and he gave a call to action to everybody in the room. He shared how his son's addiction progressed, and how there was such variability in his treatment. He shared how not only his son, but the whole family suffered from the shame of stigma. And we, everybody in this room knows this. Instead of carpools and bake sales and frozen casserole, like neighbors and friends would bring for any other disease, his family felt isolated and judged and silenced. So he asked everyone at the workshop to connect with their peers, to take this opportunity to recharge and to continue the important work, and to keep thinking creatively and collaboratively with community partners, and to build strategic partnerships about how to best approach this work. And he quoted the Surgeon General's report, which says that we have to treat addiction with the same skill and the same compassion that we treat heart disease, cancer, and diabetes. We have to focus on what works. So I want to thank you for the important prevention, treatment, and recovery efforts that you all lead in the community every single day. You all healed so many lives, and I thank you for that, and I thank you for your time.
Great, thank you so much, Tyler. So now it is your turn. We have both of our presenters up here. If you have any questions, could you please, and folks will come around and collect those and bring them up to the podium. And while we are waiting, I have just a few questions. I have lots. I'm going to put Tyler on the spot first. But Tyler, so in California's 1115 waiver, Phase 5 is dedicated to the Indian Health Program. It's the Indian Health Program, ODS. Why is this phase important to CMS?
So there's lots of interest from folks at CMS on California's work actually in Phase 5 in the Indian Health Program, ODS. I think it has to do with the nature of the relationship between this population and state government and federal government, because tribes are sovereign nations, and so it's not a Medicaid agency speaking to providers or to a constituency. It's one government speaking to another government. So I'm no expert in this space by any means, but substance use disorder has extremely high prevalence in the population, and states and tribes and other stakeholders are very interested in effective ways and delivery system approaches to help better serve those members and to help address those needs. And so when California developed their drug Medi-Cal organized delivery system, which provides essentially a county-based non-risk managed care system for the substance use disorder benefit, and the state developed targeted Phase 5 as an approach for that. Essentially, that would mean within that framework that there would be a managed care delivery system for behavioral health treatment for the American Indian population. And so that's pretty innovative. So you have the teams at CMS that work on tribal affairs and on Indian health are really supportive of this work, and they recognize what an innovation it is. So I think we're all looking forward to see what the state does.
Great, thank you. This question is for Matt. What has been the negative aspects of working with peer mentors, and how do you overcome these obstacles?
I think the largest negative that I've seen regarding integrating peers into our treatment systems has been the need for increased training and peer supervision. Quite often, many states, their threshold for entry is 1 or 2 years of recovery, which is pretty brand spanking new in recovery terms. And so the thing we encounter the most are boundary and ethical issues. John, the recovery coach, goes to a local meeting and bumps into a guy that he's working with in the program, and how do they deal with that? Issues like that come up all the time, and without good, solid peer supervision and continued training, how to navigate that system is pretty challenging.
Great, thank you so much. All right, so the next one here is, I have so many. Actually, this one's blank, it threw me off. Someone wrote in invisible ink, so please use actual legible ink for me. I can't really read those. So Tyler, can you talk a little bit about, you mentioned about ASAM being a part of 1115 waivers, and this question is about service standards for provider contracts for ASAM, and just how can providers locate those types of resources around ASAM.
Sure. So I can't speak to the specifics of provider contracts in California or in counties in California, but essentially the American Society of Addiction Medicine publishes the ASAM criteria. I think it was last updated in 2013. The ASAM criteria describes not only their patient placement criteria, which is a multidimensional framework for conducting assessments, looking holistically at someone's needs, like Matthew was describing, in order to determine appropriate level of care. But the ASAM criteria also has essentially a taxonomy of the treatment continuum. So it describes levels of care, and it's aspirational, but it describes service specifications and provider specifications for each level of care. So that's described in the ASAM criteria, and what we did is we worked to sort of boil that down and make it available on Medicaid.gov. We worked with ASAM for their review, so they took a look at it. And that's available on essentially if you go to Medicaid.gov and look at the Innovation Accelerator Program page, you can find that overview, and it includes some of those clinical details.
Great. Thank you so much. So this one is for Matt. How do you envision peer support working in California and SUD? And then the next question is, would this be a career path to a counselor?
Can you just, Marlise, I missed the beginning of the question. How do I envision peer support? What?
So for $100, which will be provided by Mr. Don Breger after this presentation, how do you envision peer support working in California in SUD?
Okay. Peer support around the country is often invoked in a variety of ways. So we've talked about recovery community organizations who kind of support the umbrella of recovery support services, and importantly peer-based solutions. So there's a number of RCOs that I'm familiar with in California, but in a state this size, more needed. Call to action. I've also, found that some treatment organizations are hiring peers, and so there's kind of a whole variety of ways in which peers are being hired right now. It's usually RCOs, it's sometimes treatment organizations, it is sometimes arms of the criminal justice system, believe it or not, and peers are working doing in-reach to make that transition, an offender reentry, go more smoothly. and they're increasingly being paired in the world of opioid use disorder with primary care physicians and other providers.
Great, thank you. All right, for $1, Tyler, I'll pay this one. So given the high rate of given the high rate of overprescription of opioids to Medicaid patients, is there any plan to increase Medicaid's coverage of acupuncture or physical therapy to help reduce the need for pain medication?
Yeah, that's a great question. So under federal Medicaid authority, there's a few different options where states have the ability to cover those types of approaches to pain treatment. So essentially, there's the opportunity for states to design and administer their Medicaid program, and those I'm not sure of all the ones you just mentioned. I sort of didn't keep track, but a number of those, including acupuncture, including physical and OT therapy, are coverable under Medicaid. So part of our effort is to highlight the value in covering those services and the risk associated with using opioids as pain management. So when we engage states and when states are looking at their coverage options, I think that's something that we try to point to.
Great, thank you. Okay, this next question is for Matt, for no money. I'm running out of money.
Straight for 600, please.
Okay, so Matt, you in your discussion today had a call to action for folks to stand up. So as a provider, how would they begin on this journey for recovery services to implement that in their program?
Excellent question. Where I've seen recovery community organizations emerge in the past, and I should have highlighted this, has often been a combination of frustration and opportunity. So like the treatment provider that I described, who was frustrated with my inability to place my clients who'd bid on the treatment apple into safe and supportive housing and provide, they didn't have peer-based support back in those days, but now they do. I often feel like I have a twin brother who's very entrepreneurial and would love to start a recovery community organization and provide all those critical care elements. And so, if you're a provider, I'm not suggesting, I might get in trouble if I suggest anyone jump ship if their boss is also in the room, but I think with open conversation and dialogue and perhaps some conversations with county funders in the state, that perhaps some funding will be made available for opportunities to jumpstart recovery community organizations, and for those who feel the calling, please jump on board. Faces and Voices of Recovery, get on their website, please. My contact information is available. Just very quickly, I just wanted to say that there are enormous resources available to you around the country. You do not have to reinvent the wheel, and we're here to help you. Thanks.
Thank you, Matt. And the last question is for Tyler. So there's been a lot of discussion. Obviously, you're responsible for Medicaid and SUD services, but this question was around what about with Medicare? So what is being done in that space? Because I know we see the statistics of it's not just within the Medicaid bounds of the population, but can you speak a little bit about that?
Sure, I can speak a little bit about that. So Medicare is doing a number of things, I think, to address, CMS is doing a number of things to address SUD and opioids in the Medicare program specifically. So I mentioned PDMPs, which are prescription drug monitoring programs that states operate. It's not always the state Medicaid agency, but every state now has one. CMS has what's called the Overutilization Monitoring System, which is similar to a PDMP. So what Medicare has done is it's put edits and flags into the OMS to identify essentially risky opioid prescribing and concomitant opioid and benzodiazepine prescribing, and it compels Medicare Part D plan sponsors to follow up on action. Medicare is partnering with the CDC. I mentioned the opioid safety poster campaign. So Medicare is integrating the CDC opioid prescribing guidelines into its education and provider outreach efforts. They're doing that in a number of ways. Medicare is identifying prescribers that are in the outlier. I think, some threshold above their peers and their specialty, and it's informing them of their, their high prescribing rates for opioids. I think one thing Medicare is also doing that I think is fundamental here is I think they're looking at the way that patient satisfaction surveys are structured, because I think currently the survey asks around whether the provider asked you about pain and is managing your pain, and that in turn is tied to quality ratings and financial incentives, which I understand to be one of the sort of primary reasons for, one of many reasons for a flow of opioid prescribing. So I think they're actually revising that to eliminate any perverse incentives for prescribing opioids.
Great, wonderful. Well, I want to thank everyone that submitted cards. I apologize that we don't have time to get to them all, but I especially want to thank Matt and Tyler for coming and spending time with us. They will be available for a little bit more of the conference today, so if your question wasn't answered or you just have a burning question or want to follow up with them, they will be out mingling. But at this time, we're going to close our plenary and we're going to move into our workshops. So we'll see you after the workshops back here.